This patient had regressed or atrophic germinal centers, hypervascularization between follicles, plasmacytosis, so plasma cells throughout, but not sheet-like plasma cells, and finally hyperplastic germinal centers. So these features are often found in a disease called idiopathic multicentric Castleman disease. They are not specific or pathognomonic for MCD, but they are certainly consistent with. Based on the really dramatic vascularization and really dramatic atrophic germinal centers, you would call this case a mixed case. So it wouldn't be plasmacytic or hyaline vascular, we would call it mixed pathology. In the setting of this patient's fluid overload, he's got 50 plus pounds of anasarca throughout his body, fluid overload, thrombocytopenia with really low platelets, reticulin fibrosis on bone marrow, renal dysfunction, and his hepatosplenomegaly, plus these lymph node findings of what we call mixed or really exaggerated atrophic germinal centers. We need to be thinking about a syndrome within multicentric Castleman disease called TAFRO syndrome. TAFRO stands for thrombocytopenia, anasarca, fibrosis of the bone marrow, renal dysfunction, and organomegaly. These patients really have been reported for decades. They've only recently been described in the literature, initially in Japan and now around the world, as a subtype of multicentric Castleman disease. So based on the really dramatic anasarca and the low platelets, that gets you thinking, could this be TAFRO syndrome? And the reason that's important is that multicentric Castleman disease is such a heterogeneous disorder that you want to be able to start to lump patients together. And what we started to find is that patients with TAFRO syndrome respond one way to therapies, and patients that are non-TAFRO multicentric Castleman disease patients respond in other ways. So in this patient, based on the constellation of symptoms and features, we are thinking that this is idiopathic multicentric Castleman disease with mixed cellularity with TAFRO syndrome.